Discussion is on the basis of the fever in parasitic diseases. Fever may occur in various causes. If you are asked what are the causes of fever, you should answer large number of causes are there. I think you know that. It may be viral, bacterial, it may be parasitic, it may be some malignancy, some rheumatological cause, and other inflammatory cause due to any source of inflammation that due to it. Now, today we will discuss the fever with parasitic infections, and these are the topics of discussion. You see, the topics of discussion are also like this: malaria, leishmaniasis, say other like say giardia, filaria, and different worms can give rise to it. We will discuss these things, and we will discuss on the basis of this etiology, pathogenesis, etc. Clinical features management. So malaria is most important. Malaria, you know why it is important, and you know also the important causes of malaria. Now we are very much afraid of Plasmodium falciparum because it can give rise to severe malaria and in children, and also it can give rise to some death of the children if it is not treated earlier. We have seen several cases of severe malaria, even in a child of say 8 or 9 months age. A child of 8 months age admitted in an emergency room in about say in the year of say 1997-8 with severe pallor from Kotulpur district of Bankura. Emergency. Now examination reveals spleen is palpable. The house physician patient there palpated the spleen. Spleen is palpable, severe pallor. Liver is also palpable, and he thought that possibly it was a case of hemolytic anemia, naturally. Ultimately, at the afternoon, during the afternoon round, after OPD, we discussed the cases and started immediately did the blood count, blood cell, to see the MPDA and MP parasites, because falciparum malaria. So it may present with acute severe anemia also. Sometimes it may present with cerebral malaria, alteration of the sensorium. Sometimes with the say black water fever. Urine is black due to some chemical substances which are present in the urine. Sometimes in the patient with this hypoglycemic convulsion or hypoglycemia features. Sometimes with cardiac failure, sometimes with pneumonia. So every organ may be damaged by this. Sometimes in the case of severe diarrhea, algid malaria. So if you start one by one, it will give rise to this. Vivax does not give rise to usually severe malaria except in occasional situation. But it can give rise to relapsing malaria. Now, the two types of things may happen. One is relapsing malaria. It means the malaria parasite, they grown inside in the liver, exoerythrocyte express the liver, and subsequently from the liver it is coming to the blood. It is in Plasmodium vivax and Plasmodium ovale also. But ovale is not very common here, maybe common in other countries, etc. And in the case of Plasmodium falciparum, some parasites were present in the RBC in the dormant stage and can give rise to infection that is called recrudescence. So this is the difference between relapse and recrudescence. Relapse from the enlargement parasite in the liver, then causing the infection again, and recrudescence means present in the RBC itself. So let us go to the next page. Pathogenesis. Actually, you have learned these things in the microbiology, parasitology, etc. So we are looking. This is sporozoites from the infection. Sporozoites where it is coming from mosquito bite, Anopheles mosquito bite. Okay, and then through the blood it goes to liver, and from the merozoites invade RBC, and merozole is converted to physiogony. Then rupture and fever. So what is the cause of fever? There is rupture of the RBC, giving a release of the physiogony, and also there is release of the cytokine, different types of cytokine which are giving rise to fever. Next thing is that in case of falciparum, what is happening? The RBC which are infected with the falciparum, they have some adhesive materials in the cell surface. So what will happen? They form easily the roller formation. They adhere together. And whenever they form the roller formation, that may block the capillaries in the microcirculation. Capillaries in the microcirculation. So in the cerebral malaria, that can give rise to ischemic damage to the brains. At the same time, the falciparum parasite itself can give rise to cytotoxicity. Okay. Similarly, it can give rise to the block in the circulation in the kidney and also in the intestine, in the lungs. It's a various. So at various places, it can give rise to some blockage of the vascula. This is called the Plasmodium falciparum-induced vasculopathy, giving rise to multi-organ failure sometimes. So this is a cycle that you know from the, it is not required, it is, you will get it at any book. It is going from mosquito as it says sporozoite and then coming back to the mosquito again after the bite hatch. Okay, the mosquito usually taken the gametocytes in the blood. So gametocytes are present in the RBC. So first sporozoite entry goes to the liver and then proliferate. Merozoite seasons burst. Merozoites coming outside attack the RBCs. Again they converted to seasons and seasogony phase. Then they rupture and give rise to fever and other manifestation, and some of the merozoites and schizocytes, they converted to gametocytes. Female gametocytes are larger one, that's called macrogamete, and male are smaller microgamete. These gametes are taken by the mosquito and they unite in the mosquito gut. And then when the oocyst is formed, they penetrate the intestine of the mosquito. Okay, again the same cycle going on. The oocyst to season, then to merozoite, then to sporozoite, and these sporozoites are coming in the mosquito. And when the mosquito bites, the sporozoite is going to the human mix. So this is the cycle. This is not very, you know it from the clinical picture. I think you know so far the discussion is done. It may be anything may be there, maybe high fever to shock, anything may be there. Some confusion, convulsion, etc. So we are not going through details. Severe anemia may be although I discussed these things. We are also discussed this, what is happening in cerebral malaria. Now the management part. There are in India there are some modification of management. Not like say other places. India, you see the Plasmodium vivax treatment in India, the first drug is chloroquine. Till chloroquine is the drug. Till Plasmodium vivax. Though chloroquine resistance is coming in case of Plasmodium falciparum, but vivax is more sensitive to chloroquine. And you see the chloroquine total dose is 25 mg per kg divided into 10, 10 and 5. First day 10, second day 10, third day 5.
So the doses are adult.
So usually this is you go to the last doses, it is giving there 25 mg per kg.
Per kg to pediatrics
per kg. Suppose the 10 kg, it should be 250 mg. And it is divided into 3 days. In adult, 4 tablets first day, 2 tablets second day, 2 tablets third day. So that is for adult, total 10 tablets, 8 tablets. এটা আমরা দিতাম সেই হাউসটা অনেক আগে 422 ঠিক আছে so we are going to pediatric age group so 25 mg per kg you can do and if you go to this for radical cure you should give pymaquine and 3.25 milligram per kg for 14 days. There are maybe opinion varies. Some says it may be 7 days is enough. Some say 14 days. One thing you should take care of, there is a glucose 6-phosphate dehydrogenase, G6PD. Some babies, they may suffer from that deficiency, and by pharmacology oxygen drug, so it can give rise to hemolysis. Okay, so we should take care of, or should be vigilant about whether there is any hemolysis or other things is going on. Now, remember there are chances of relapse because some say merozoites are converted to hypnozoites. Hypno means looky ache. Hypnozoites in the liver, and that may proliferate later on. Okay. Now, pymacoin should not be given in pregnancy. Okay. In pregnancy, you should not give the pymacoin. That way you see it is clearly mentioned. It should not be given the pymacoin. Also, in children or infant who are having glucose 6-phosphate dehydrogenase deficiency. So I think this picture is clear. Next, go to the next plate. This is also a falciparum. This is called potentially fatal type of malaria. Fatal. It may be severe malaria or say potentially fatal. In India, the dark-eastern pattern you should clear. The northeastern states, the dark-easterns present in some areas. And also in this part, eastern part, there is dark-easterns is different type of. So treatment, India government gives this type of treatment. Okay, what is this you see? These are the states, Arunachal Pradesh, Assam, Manipur, Meghalaya, etc. Resistant infection. Artemisinin-based combination therapy. Artemether and lumefantrine. Duration 3 days. And pymacoin, 175 mg per kg on day 2 to kill the gametocytes. Is it clear to you? So, gametocytes can be killed by pymacoin. And here in this country, in these states, northeast states, these combinations are used. In all other states, the treatment in our states, treatment is artesunate and sulfadoxine pyrimethamine, artesunate for 3 days, and single dose of some. A single dose of pymacoin is present in both the cases. Okay. Treatment of severe malaria. Malaria is same thing, just given IV. It should be given IV, and artesunate is the drug of choice, 2.4 mg per kg, 0, 12 and 24 hours. Then daily. Even follow-up, once the patient can tolerate oral medication, then full 3-day course of oral artesunate-based therapy. Yes, depending on the region, just previously described. Ever, what is this? These things to continue then daily means key. So long the patient is able to take orally. This is important. Previously, during our period, when artesunate was not available, then we give you quinine. And we have got good result also, quinine. Even pregnancy, in pregnancy you have the doubt of the artesunate or pymacoin. Quinine is given. Quinine. Okay. The quinine, one thing is that quinine should be given IV, not orally, and 10 mg per kg daily for 7 days. But quinine, one side of it is hypoglycemia. So you should take the blood sugar. This is an important question for PG entrance also. Next we come to Kala-Azar. I think you know the Leishmaniasis is more common in different states. Bihar is common, but Now in West Bengal also, Bhatar area, অনেক pocket Bhatar Kedukam is very common site. They are also given large number of cases Kala-Azar. And nowadays Kala-Azar, previously we diagnosed Kala-Azar by seeing the pallor of the patient. Huge abdomen, so spleen is very enlarged. Splenohepatomegaly, correct. Spleen is very much enlarged. And there is severe pallor also. And usually we do bone marrow previously. We did usually bone marrow. Nowadays also bone marrow is done. And so the LT bodies, amasticate form. In amasticate form, it is so like this larger, flagella is there, amasticate, there is round form. So amasticate form is diagnostic. Now there is another antigen test is available. Antigen test, K39 antigen. Kala-Azar 39 antigen you can detect. Skin test করা যায়, বলছি 39 antigen is easily available and it is done. So whenever there is fever, now Kala-Azar is some going down also due to different reasons, but you can diagnose. Still in some areas Kala-Azar is coming. Now who is causing Kala-Azar? Either you see the female phlebotomous urgentavis. This you should remember. And here is also a masticate. It is coming from the mosquito, and it is going to engulf by the macrophages of the human skin. Sandfly bites, masticate releases, macrophages engulf that, converted to amasticate. Then it is a reticuloendothelial system, hyperplasia. So RE system is involved. So it may be involvement of the spleen, lymph nodes, bone marrow, everywhere it is involved. Okay. So this is the same thing which is shown by picture. Masticate converting to masticate is going to amasticate form, releases, and it is sandfly taking the masticate, say amasticate, and converted to masticate. Masticate enter inside the human beings, converted to amasticate. This is the cycle. So clinical picture we discussed that it is just invaded the bone marrow, pancytopenia will be there, invaded the reticuloendothelial system, spleen will be enlarged, severe pallor will be there, and infection is very common. In Kala-Azar patients, you can get other infections are common. Even tuberculosis is also common in Kala-Azar. Sometimes mixed infection, malaria, Kala-Azar may be present together. There is definitely, say, weight loss and other things will be there. And due to this, say, pancytopenia, prolonged fever, double quotidian pattern. This pattern is not available nowadays. Quotidian means fever is coming daily, right? Double means it is coming twice, either in the morning and evening, double rise of temperature. Now there are sometimes previously, during our time, we will have to tell to examiner, double rise of temperature coming in the Kala-Azar, pale abstain type of temperature present in the Hodgkin's disease. This type of terminology there. Stapler pattern in typhoid, etc. Now this type of say fever pattern or say severe hectic rise is septicemia. That is septicemia is there, but in other cases, as the antibiotics and other things are interfered before your presentation, so this type of pictures you are not getting now. These are the classical pictures, double rise of temperature. Complications, we have discussed all these things. Now here we usually give the urea stuamine injection. I have given several doses of urea stuamine in medical colleges. Okay, urea stuamine. Nowadays, the liposomal amphotericin is available. Okay, so as the amphotericin is available, in the last part, would form say 84.5 amphotericin B is available. And one of the article published in the Indian Journal of Pediatrics, first from Bihar. From Bihar, they say that amphotericin B is very much effective, that can be given. And amphotericin B previously it was very toxic also. But subsequently the liposomal amphotericin B is there and there is less toxic in comparison to other.
স্যার দুটো ফর্ম যেটা আছে কনভেনশনাল আর হচ্ছে লাইপোসোম
হ্যাঁ।
দুটোর মধ্যে মানে পার্থক্য কি আর ব্যাপারটা?
Conventional is very much toxic. Dose is required for higher doses. Liposomal dose duration is less, toxicity is less, and also approach is very good. It goes to a direct tissue sites.
মানে ফর্মুলেশন
Formulation to liver. ঠিক আছে? So you see this is you see বলে দিচ্ছি তবু দেখো liposomal amphotericin B 3 to 5 milligram per day for 7 days, and the conventional should be given for 20 days. So to total cure. Now this concept is also coming 10 milligram per kg single. This is the say 25 program, national program 2025, and 205 this modification is there, and other you know the miltefosine etc. carbamazepine. So these are not because liposomal amphotericin B is sufficient, not it is sufficient. Nothing else is required.
এটা এমসিকিউ আছে আরকে 39 যেটা
এটা ঠিক আছে ডিসকাস
what is the gold standard
now extraintestinal MBBS can give rise to fever. Only intestinal MBBS usually does not give rise to fever. It can maybe fever but low grade fever. These are very say high grade other things, but extra MBBS is the extraintestinal MBBS. Suppose there is in the liver. During our period, we have seen the large number of cases of liver abscess. I can say, remember one case during my house staff period for 50 years of age, suffering from pain abdomen and say intercostal tenderness is present, and liver is palpable. Intercostal tenderness is present. There is no this is about at the time of 83, 84. There was no question of USG because USG was not in West Bengal till that date. 83, 84. USG appeared first taken by Dr. Sharma. Dr. Sharma echo X-ray is fast USG, and we used to go to see how USG is done and other things. Similarly, a CT scan is also by Dr. Sharma, also MRI by Sharma. Echo X-ray is actually generate all these things. Then subsequently displayed. USG was not there, but so clinical picture is all in all. And you can hardly do an X-ray, but X-ray usually X-ray doing the liver abscess and showing the liver abscess is very difficult to interpret. So what we do, so we penetrate house staff subject. During that time there was no consumer forum also. So we used to take a needle and then push it there, okay, and how the needle here and there was pushed and turn. And I have found near 500 milliliters of pus from one patient, and he survived. So this is what they say, extraintestinal MBBS. Fever is there, pain is there, chest pain, and definitely liver is palpable. So you see the matter is
high fever
just abscessive diabetes. So you see these things topoid from colon, portal from liver, necrotic abscess. And this is Gametocytes type and Gametocytes type of pus. These are the terminology used by pathologists. And if you read the pathology by Boyd, during our time the pathology by Boyd. Boyd তোমার pathology খুব এখন তো বিরাট পাওয়া যায় না বোধহয় বইটা। এখন রবিন্স খুব ভালো বই। বয়েড হচ্ছে আমরা স্টুডেন্ট লাইফে পড়েছি, আর রবিন্স হচ্ছে পিজি প্রিপারেশনের জন্য পড়েছি। বয়েড হচ্ছে তোমার বয়েডের হচ্ছে হিস্ট্রি, মানে পাতার পর পাতা লিখে যাবে আর কি, লিখে যাচ্ছে গল্পের মতো করে, খুব ইজি বুক, কিন্তু ইট রিকোয়ার্স টাইম, প্রচুর মোটা বই লিখতে পারবে না, লেখা সম্ভব না। ভেরি গুড বুক, কনসেপশনের জন্য দরকার। সো দিস টাইপ অফ ডেসক্রিপশন দেয়ার। This is the liver abscess picture. So it is not too much difficult. Blindly we introduce the needle here and then push here and then the pus is coming. So every time you are drawing the needle. ঠিক আছে? withdrawing the stellate and seeing what is happening. Clinical picture, I think it is not required. So remember, the history of dysentery may be absent. Naturally, we may think that dysentery history should be there, but 60-70% it may be absent, but maybe actually in 30% of it. Complications, definitely, it may rupture anywhere. Management this. There is another thing that is called, say, amoebic hepatitis. This was also very much common during our time. We have seen one patient, say, 35 years age, worker in, say, Beersing Hospital, so by Beersing Hospital, due to pain in the right side of the chest and left side of the chest both, and ultimately diagnosed by ECG as ischemic cardiac disease. And the patient was in cardiac medicine, but there is no improvement. During our time, just during the house staff time, and one professor was there, P.K. Basu sir was there, and a house staff examining the case, and that sir, liver is like tender. Sir also examined, ultimately it was diagnosed as amoebic hepatitis, and to have given the metronidazole, and the patient improved for 10 days, completely improved. And subsequently metronidazole 7 days followed by diloxanate fluoride to kill the cyst. Okay, the patient is improved. So, amoebic hepatitis. Giardiasis, you know about the Giardia matter. The most common cause of, say, malabsorption syndrome in children. There is a bulky stool. So much so that sometimes mother says that stool is more than the average expectation from the child. ছেলের থেকে পায়খানা বেশি হচ্ছে. This may be the complaint. And also there is no gain of weight, abdominal distance, and etc. So these are things. So what you would like to say that the giardiasis is not uncommon. You should suspect, and shape the system, giardia itself. But it is very difficult to diagnose, except a very expert can diagnose this. Otherwise, very difficult. Also, they are not also available. Sometimes you need to do duodenal aspiration and then sometimes it needs. So that is feasible, not feasible. So sometimes we have to give arbitrarily medicine for giardiasis. That's I discuss what is I'm going to do. Malabsorption syndrome, all features will be there. Deficiency will be there. Complication, secondary bacterial growth, obviously malabsorption. Here there is nutritional deficiency, the infection will be there. So here the metronidazole for 7 days or tinidazole single dose 50 mg per kg. Nitazoxamide, it was not present during our time. It is a good drug recently, and it is a 100 mg BD or 200 mg BD depending on the cases. You can give 10 days. It is a broad spectrum drug. It can kill giardiasis. It can give Helminthiasis also. But there are some side effects. It can give rise to vomiting, bloating, more bloating of the abdomen, and the urine is very, very, very dark yellow, very much yellow. So usually parents refuse to take the nitazoxamide. The marketing is not very good with this. Filariasis kintu not very uncommon in some places. Actually, government has to take program for filariasis. They are giving diethyl carbamide citrate. Heterozole is বাড়িতে দিচ্ছে. Because of this, national filaria control program is there. So it is not uncommon. With various type of presentation will be there. Sometimes you will see one of the limb is swelled. Now why this? Because microfilaria present in the lymphatic channel, say filaria, and that can block the lymphatic drainage. sometimes the small channels in inguinal regions, they may block. That can give rise to the swelling of the upper part of the thigh sometimes. Or sometimes there is a painful sensation, sometimes a swelling of the genital organs. So filariasis is a lymphatic filariasis, which is a bankruptcy, the most common, and rarely by the Malay. So what is happening? Worms. Actually, worms here means filaria. It is present in the lymphatics, giving rise to inflammation, lymphangiectasia, swelling, and helminthiasis. Sometimes this inflammation can give rise to dermatolymphangioadenitis. You will say gland swell, some dermatological involvement. We have seen cases, say a 7 or 8 years old child, patiently with a pain in the upper part of the thigh, medial aspect, groin, pain in the groin. And the finding, there are now no other findings are there. Arbitrarily, we started the diethylcarbon citrate, etragen, 6 mg per kg for say 12 days or 15 days. Patient improved, dramatically improved. Sometimes you see the swelling of the testis orchitis. There is no history of trauma or other things. And USG shows there is no torsion. Only some information is there. We give the etragen to be improved. So these usually we have seen cases. 2 or 3 years back we have seen several cases. Nowadays the cases are less.
Yes.
But there are cases. This is the cycle. I think you will know all this cycle. What is happening in the say human beings? Actually, a mosquito shape. What is happening? The larva, there are 3 stages: larva 1, larva 2, larva 3. This is the microphylla larva 3, and that enters the human body by bite. Okay, mosquito bite. And after entry, they enlarges and they block the lymphatics. And then when the adult worms, they release the microphyllaria, they are taken by the mosquito. They are taken by the mosquito. Okay. So when the microphyllaria are released in the blood, during that time, they preferably do it at any time, but preferably at night time they released. The patient may get fever. So sometimes it was thought previously that during the height of fever in filaria, you draw the blood and see for microphyllaria. But subsequently it was found that it is not very easy to get microphyllaria.
ব্লাড স্ট্রিমে আসবে তখন ধরতে
তার
হবে।
জন্য যদি স্যার ওই ডিসি প্রভোকেশন টেস্ট
হ্যাঁ
আর সেটা তো করতে, সেগুলো তো করতেই হবে, পরে আসছে। You can get nowadays a filaria antigen, you can detect it by ELISA test, okay, DEC provocation test, etc.
এখন কমে গেছে।
হ্যাঁ, কমে গেছে। So,
আগে মোটামুটি যে কোনো গ্রামের দিকে গেলে মানে
পাওয়া যেত,
বেশ পাওয়া যেত, বেশ মানে বেশ বয়স্ক মানুষ,
হাইড্রোসিল,
এরকম পুরো বড় একটা পা,
হেলিফ্যান্সিয়াসিস।
পাই দেখা যেত, এখন আর দেখা যায় না।
So these are the clinical pictures of fever with being present, and this is the management. Mass track administration, what is going on in the program? See the program. This is the albendazole and 6 mg per kg DC, single dose yearly. And during attack, you give for 12 days and supportive care. What I described there. Now, these are the Helminthiasis, which can give rise to also different types of manifestations. Now, Ascaris lumbicoides, hookworms, Strongyloides tuberculosis, and Toxocala. So, Ascaris, you saw the human in the reservoir, human and the host. Actually, what is happening? The infection is element is going in the soil also. So it is a disease of poor hygiene. If the hygiene is good, that will not happen. Now, this ascariasis can take the lives also. They are present in the gut. Sometimes they may block the gut itself and then give rise to blind loop syndrome. বুঝতে পারছো? একদম ইন্টেস্টিনটাকে ব্লক করে দিল। আমি মানে মারা যেতে দেখেছি। বাবার একটি ছেলে, 8 বছরের ছেলে ভর্তি হয়ে যায়, ছটফট করে মারা গেল। অনেকদিন খায়নি বা তখন আর কিছু উপায় নেই কিছু, একদম ব্লক হয়ে গেছে, ইন্টেস্টাইনাল অবস্ট্রাকশন নিয়ে প্রেজেন্ট করেছে। সার্জনও কিছু করতে পারে না, রিমুভ দ্য ইন্টেস্টাইন উইথ দ্য লার্জ ওয়ার্মস। এরকম ওয়ার্মগুলো বিভিন্ন জায়গায় ছড়িয়ে ছিটিয়ে চলে গেছে।
এটা ডেঞ্জারাস, এটা পোর্টাল ভেনে ঢুকে যায়।
হ্যাঁ, পোর্টাল ভেনে ঢুকে যায়।
এরা ডিউডেনাল ওই জায়গাটা স্ফিংক্টারটা ওই জায়গাটাতে ব্লক করে দেয়।
ব্লক করে দেয়। Anyhow, they can go. This is a hookworm. You see the from the through the entry. Entry and then gradually spread it. Again, it is within the human itself. Hygiene is the most important thing to maintain. Strangulars. Life cycle is being. Here the different types of say the other say cattle and other things. They releases eggs and that is enters into the body and then gives rise to this. These are the invasive disease. The invasive disease. And when they give rise to invasive disease, that can give rise to eosinophilia. And also various manifestations of the strangulars. Sometimes it will go to the liver and through the bile duct and obstruct the bile duct itself, just like roundworm also. Okay. Strangulars manifestation maybe there are also in the say bladder can fill up with these, and sometimes hematuria may be presentations. Though it is rare, not very common. Now the other say manifestation, you see the toxocora, visceral life of migrants. So any type of this will be there, and strangulars can give rise to gram-negative sepsis like fever, hookworm, iron deficiency anemia, most common cause, and roundworm say. When during migration to the lungs can give rise to fever, cough. Yes.
টক্সোকারা তো কুকুরের থেকে আসে, টক্সোকারা ক্যানিস।
হ্যাঁ, ক্যানিস আর ক্যাটিস দুটো আছে।
কুকুর আর
বেড়াল, কুকুর বেড়াল এসব থেকে।
ক্যানিস মানে ডগ।
হ্যাঁ,
ক্যাটিস মানে ক্যাট।
হ্যাঁ, ক্যানিস তো ডগই, কারণ ক্যানাইন থেকে আসে।
ক্যানাইন জানি। মনে রাখবে যে ওগুলো ওদের যে ওরা যে স্টুলটা পাস করে, ওইখানে ওই স্টুলটা কোনো কারণে যদি একটা চলে যায় তখন পেটে চলে গেল, যে ছেলে ইনভেশন হয়ে গেল আর ওয়ার্ম হয়ে গেল, ইনভেস্ট করতে শুরু করলো। এটাই হচ্ছে মূল মেকানিজম। এবার সেই ইনভেশনের জন্য বিভিন্ন ম্যানিফেস্টেশন। তাহলে আর আমার মনে হয় বিশেষ কিছু নেই। এদের ক্লিনিক্যাল পিকচার্স দেখো, same thing happening when it's going to lung pneumonia, when you go to say hepatosplenomegaly pneumonia, etc. That can give rise to this. Involved in the brain can give rise to seizure also. There are some parasite maybe there. Can you tell me the name of that? Involving in the brain can give rise to seizure, convulsion. And it present in 1/3 of the cases of the epilepsy, when convulsive disorders may be due to that cases in India. That is called neurocystic sarcosis, tinea solium and saginata. These are not giving at your course here, maybe. Okay, but you should know the neurocystic sarcosis, you should know. It is present almost in the brain, sometimes it is present in the muscle also. এইখানে একটা কেস হয়, রেটিনা তো মারাত্মক হয়ে যায়। এইখানে একটা কেস হয়, মাসলটা এক ঘুরে হ্যাঁ তো বলেছিল ও ইয়েটা আসছে একটা সিস্ট করে আসছে। আমি দেখলাম যে থাক ঠিক আছে, আমি দেখি অ্যালবেন্ডাজল 15 দিন দিলাম, কমে গেল আস্তে আস্তে।
মাসেলে আমি দেখিনি কিন্তু
ওখানে ঢুকে বসে থাকলে তো হবে। একটা যদি মাথায় যায় মাসেলে কেন যাবে না, চোখে যাচ্ছে, চোখে হচ্ছে, তাই না? It can go anywhere. কমন সাইজ হচ্ছে এটা। এই ম্যানেজমেন্ট দেখো, হ্যাঁ অ্যালবেন্ডাজল তুমি তো এটা তো তুমি তো রাউন্ড অফে চললো, রাউন্ড অফে কিন্তু 15 days পরে একটা রিপিট করতে হয়। আফটার 15 days you should repeat albendazole, should be repeated. Albendazole should be given 100 mg twice in 3 days, not 500, 600 mg. এটা গভর্নমেন্ট অফ ইন্ডিয়া লিখেছে এটা, but you should be given that. And also the in case of albendazole you should repeat after 15 days, not 7 days, it's 15 days. You know why? Because some say eggs may be there, activity. Sometimes we get the resistant helminthiasis. It means when the mother is comparing that almost every month anti-helminth are required, every month. So what should I do? Parents may ask you. In that case, you may think about the resistance helminthiasis. In that case, the treatment of written here, it is a treatment is that 5 days continuously albendazole therapy, and after 2 weeks gives another 6 dose. And also the family should be deworming, should be given deworming. তাই না?
একটা হচ্ছে কনস্টিপেশন থাকলে তার ট্রিটমেন্ট,
হ্যাঁ কনস্টিপেশন ট্রিটমেন্ট করতে হবে,
নালে ও
জমে থাকবে। ঠিক আছে। আর visceral leishmaniasis with the albendazole, also in case of say neurocytic sarcoidosis, active, not calcified, active neurocytic. That means the neurocytic sarcoidosis in the brain associated with the peripheral edema, or in the muscle associated with edema. It means they are active. Inflammation is going on. During that case, you can give the albendazole, but steroids should be given in that case. Otherwise, there will be reaction. I got a severe reaction at Kalna. Patient is ultimately goes to other doctors because of the mistake. Steroid is not given, only albendazole given, and then there is reactions and patient develop convulsion. So other consulted other doctors and the steroids and everything improved. Steroid reduces the edema. Also anticonvulsive drugs.
আমি এরকম করতাম না যে আগে স্টেরয়েড স্টার্ট করে তারপরে অ্যালবেন্ডাজল আমরা
দিতে বলে, আর সেটা সবসময় ব্রেন এডিমার ক্ষেত্রে ভালো।
তাহলে পুরো ব্লাইন্ডনেস,
হ্যাঁ রেটিনাতে আগে তোমার স্টেরয়েড দিতেই হবে।